All right, let's jump right in. Today, we are tackling a huge topic for your anesthesia finals, ventilator weaning. Seriously, knowing when and how to liberate a patient from that vent, well, it's an absolutely make or break skill. So, let's get you ready to crush this on exam day.
So, here's our roadmap. First, we'll get a solid grip on what weaning actually is. Then, we'll cover how to tell if a patient is ready for it. After that, we'll walk through the spontaneous breathing trial. And of course, we'll dive into what to do in those tough cases and finish up with the key trials and numbers you absolutely have to know.
Okay, let's do this. First things first, what are we really talking about when we say weaning? And more importantly, why is getting that timing just right so incredibly crucial?
You know, at its heart, weaning isn't just flipping a switch off, not at all. It's a really careful, gradual process. Think of it like a handover. We're slowly dialing back the ventilator's support, and we're asking the patient to start picking up the work of breathing all on their own, with the big goal, of course, being extubation.
And this, right here, is the tightrope we walk every single day. If you go too early, you're looking at things like exhausted respiratory muscles, aspiration, maybe even losing the airway. But if you wait too long, you open the door to a whole other set of problems, like ventilator-associated pneumonia or lung injury. It is a delicate balancing act for sure.
Now check this out. The great news is that for most people, about 70%, that huge slice of the pie, it's what we call a simple wean. They succeed on the very first try. But that leaves a pretty significant 30% who have a much tougher road, facing a difficult or even prolonged wean. These are the patients who are really going to challenge you.
So if timing is so important, what exactly are we looking for? How do we even know if a patient is ready to try breathing on their own? Well, it all starts with a very careful pre-flight check.
Before we even get to the numbers, we start right at the bedside. The first, most important question is the original problem that put them on the vent getting better? From there, a simple ABCD approach works wonders. A for airway, is it protected? Can they handle secretions? Do they have a cuff leak? B for breathing, are they making an effort on minimal support? C for circulation, are they stable? And D for disability, are they awake enough to follow commands? Honestly, this is a fantastic framework to keep in your back pocket for your exams.
And this is just a brilliant example of how we all try to wrap our heads around these concepts. I mean, this could be a page right out of your own notebook, right? It's breaking down all the criteria, organizing thoughts around things like oxygenation and muscle strength. It's the perfect way to structure this for recall.
Okay, so clinical judgment is vital, but you have to back it up with cold, hard data. These right here, these are the numbers you just have to memorize. We're looking for stability across the board. Heart rate under 140, a stable blood pressure, no fever, and really good oxygenation, specifically that PaO2/FiO2 ratio of 200 or better on minimal support. And then there's the big one, the RSBI. You really want to pay attention to this. The Rapid Shallow Breathing Index, or RSBI, is a classic super high yield number. All it is the respiratory rate divided by the tidal volume. A value under 105 tells us the patient's breathing is efficient. They aren't just panting, they're taking breaths that are deep enough and slow enough to actually work. It's your #1 predictor for weaning success.
Okay, so the patient's looking good, the numbers are lining up. What's next? We don't just pull the tube out. No way. We have to put them through a formal test, and that test is called the Spontaneous Breathing Trial, or SBT.
The SBT is a really structured assessment. First, you pick your weapon of choice, a simple T-piece, a bit of CPAP, or maybe some low-level pressure support. Then you run the trial for anywhere from 30 minutes to 2 hours, and during that whole time, you are watching them like a hawk for any sign of trouble. If they pass with flying colors, then, and only then, do you start thinking about extubation.
You know, knowing when to stop the trial is every bit as important as knowing when to start it. These are your absolute red flags. A respiratory rate cranking up over 35, oxygen sats dropping, a heart rate over 140, or just obvious signs of distress, like agitation. If you see any of these, the trial is over. It's done, and the patient goes right back on full support. Now, here's a key study you should definitely know for your finals. Sabira from 2019. What they did was compare 2 different ways of doing an SBT, the old school 2-hour T-piece trial versus a much shorter 30-minute trial with a little bit of pressure support. And the result was pretty clear. The 30-minute pressure support trial led to a significantly higher rate of success. So what's the takeaway? A shorter, slightly supported trial might actually be better.
So what happens when the SBT fails? Or what if it fails over and over again? This is where we get into the really tough stuff, difficult and prolonged weaning.
and we have to start thinking about our next moves.
Look, weaning failure is almost never just one single thing. The problem could be central. Maybe their drive to breathe is low because of sedation. It could be a problem with the pump. The muscles are just too weak, which happens a lot in critical illness. Or it could be that the lungs themselves are just under too much load from fluid or secretions. Your job becomes being a detective to figure out where that chain is breaking. And that leads us to a really common and important clinical crossroads. When a patient just isn't making progress, the conversation will always turn to this. Is it time for a tracheostomy?
A tracheostomy has a ton of benefits for a patient who's going to be on a vent for a while. For starters, it's way more comfortable, which means we can cut back on sedation. It also makes weaning easier, helps with mouth care, and can even let the patient start to talk and communicate again. All of these things are huge wins.
But does the timing matter? While the huge TrackMan trial from 2013 looked at exactly this, they compared doing a tracheostomy early, within 4 days, to doing it later, and the result was surprising. It made zero difference to mortality at 30 days. But, and this is the key point for your exams, the early tracheostomy group needed significantly fewer days of sedation. So while it may not save more lives, it definitely improves the patient's experience.
Okay, let's bring this all together. We're going to do a quick rapid-fire review of the absolute must-know stuff to make sure this is locked in for your finals. Think of this as your digital flashcard. Let's burn these into your brain. RSBI, less than 105. Respiratory rate, less than 35. PaO2/FiO2, at least 200. PEEP, 8 or less. Systolic pressure, nice and stable between 90 and 160. And a successful SBT runs for 30 to 120 minutes. Got it? Good.
The big point here is that weaning should never, ever be a random process. It has to be systematic. This algorithm here is basically your playbook. It maps out the whole journey, from the daily checks all the way to what you do after the tube comes out. This is your mental model.
And I'll leave you with this final question to chew on. We've talked a lot about algorithms and numbers, and they are absolutely essential. They give us a clear path. But where in this very logical flowchart do you think the art of medicine, your gut feeling, your clinical intuition, where does that matter most?
We pulled all this together from a few great sources, including a really solid review from 2016 by Zane and colleagues. Feel free to check those out if you want to go even deeper. Thanks so much for tuning in.